Sir, is it advised to do a glaucoma fellowship straight after post-graduation?
So, Rohan, at the very start, let me say I'm very excited and very grateful that a cataract cohort like the IRSI has invited me. This is the first time in my practice of nearly 26 years that a cataract cohort has invited me. They normally don't invite me because I indulge only in glaucoma. So I'm very excited and happy that you've invited me. This is the first time in my life. And perhaps if I say something which is contrary to what a cataract surgeon does or thinks like, please excuse me, it's because of I don't know anything else. So there's a bias there. I will make a disclosure statement because my aim is to woo as many people as possible to think of a glaucoma fellowship instead of a non-glaucoma fellowship. So if there is a bias, please excuse me for it. It is purposely introduced. So Rohan, your question was, should you do a glaucoma fellowship short term or long term?
No, sir, straight after post-graduation.
So what else can you do, Rohan, if I ask you after post-graduation?
No, so would you first go in and do a senior residency, own your skills in general ophthalmology more, or would you straight away go for a glaucoma fellowship? If your long-term aim is to become a glaucoma consultant.
So, Rohan, I would rephrase this and say, do I need to do a fellowship? That is the first question. Now, when you come out from a medical college after doing your post-graduation, my question here is, do you have the confidence? Now, the answer to that is very close to zero. All you have is a degree, but you don't have the ability and you don't have the numbers under your belt to get that confidence. So as individuals, you're now going to start thinking in terms of a fellowship program. The reason why I say fellowship program is you think in terms of a senior residency if you want to get into the government setup. You think in terms of a fellowship if you want to step outside. There are not enough jobs in a government setup, or maybe the private colleges do offer. I'm not very aware of that. But remember, you don't need a skill set to get a senior residency. And normally, ideally, the postgraduate system should have been at a level where by the time you are finishing, you have the confidence to go into practice. Over the years, that part has eroded. You could do a senior residency, but what would you gain? You would only gain the numbers, nothing else, right? Would you be able to do a cataract surgery with finis as a part of your senior residency program? I doubt, because you're not going to be supervised. So again, yes, there is a need to do a fellowship, because if you go into the practice and you apply to a hospital for an attachment, they will give preference to a person who's done a fellowship program as compared to one who's not done a fellowship program. See, these are the realities that are happening. Patients are also getting aware about it. They would like to go to a fellowship trained person. It's like saying, I have a headache, so I would go to a neurologist. I will not go to a general physician. If I have a stomach upset, I like to go to a gastroenterologist, and again, not to a general physician. So these are the concepts which are building up in society. And you would need to take an individual decision as to what kind of a setup. But yes, I think a fellowship by itself is a must. Fellowships would then again get graded into, say, primarily a cataract surgery and a non-cataract surgery fellowship, for example, glaucoma, retina, oculoplasty. Now, the question you have to ask yourself is, what is it that you want in life? What is it that you should be able to do? So do you want to have a practice primarily of cataract surgery? Then you need to have some basic skills of retina, glaucoma, and oculoplasty, because these are factors which you will require. For example, before you take up a patient for cataract, you need to rule out a detachment, you need to rule out macular degeneration, other conditions which can influence the outcome of your cataract surgery, so that you can forewarn the patient. Same thing about glaucoma and from an oculoplasty point of view. Now, look at it from another perspective. You want to do cataract surgery. Fortunately, and I'm talking now, taking glaucoma fellowship as an example, all fellowship programs in the country, whether they're glaucoma or non-glaucoma, they give you adequate training in cataract surgery. So that is something you don't need to worry about if you take a non-cataract specialty. You would get the skills. Now, I'm trying to tell you that if you do a glaucoma fellowship, you will still do cataract surgeries. You will still do patients with pseudoexfoliation, as was discussed. You would still get to operate on patients who are operated glaucomas. You'll still get to operate on patients with an angle closure. And you'll have the opportunity to do combined surgeries. As a cataract surgeon, is there something more you would like to do? There may be that routine nuclear sclerosis, 2 or 3, uncomplicated. When your hands are going to be full with difficult cases, you would perhaps not want to do cataract surgery in simple cases. So you do a glaucoma fellowship, you do cataracts, you are handling the difficult cataracts, and you have a specialty fellowship for yourself. So glaucoma is a good fellowship program to choose for, because you get to be a cataract surgeon, you get to operate on subluxated lenses also, as a person in a cataract surgery program does. But you have a niche area for yourself for glaucoma, where you can get to do high-risk surgeries, you can do advanced glaucoma surgeries in advanced glaucomas, and not just operate. Handling glaucoma patients, you need to talk. Most cataract surgeons today meet their patient only on the table. Glaucoma surgery, You counsel the patient before surgery. During surgery, you're talking to the patient. And after surgery, there's a lot of things. In fact, glaucoma surgery, trabeculectomy is an easy surgery to do. But it's a surgery which requires a lot of post-operative manipulation. And that's where your tricks that you want to pick up in a fellowship program will come into play. Cataract surgery is like that Hero Honda ad, no, fill it and forget it. But glaucoma surgery, the fun starts after the surgery has been done. Now, my question to you is, every glaucoma patient is a challenge. Every cataract surgery is a challenge, but the challenge goes away after the surgery has been done. Glaucoma patient, the challenge remains for you for life, because there are only guidelines. There are no definite rules. You have to individualize everything. So you are thinking constantly on your feet. And it's an encouraging, your line of management would vary from my line of management. And you've seen that today. And I purposely try to express my difference of opinion, because every patient can be managed in more than one way, even though our goal remains the same. Prevent patients' vision-related quality of life, maintain patients' vision-related quality of life. Now, as a generalization, it makes sense. But remember, if I'm a glaucoma specialist and I have a cataract surgeon, the approach is going to be different. A cataract surgeon, when he sees a patient with a high eye pressure, will say, give mannitol, pressure will come down, I'll do the cataract surgery. A glaucoma specialist will say, why was that pressure high? I need to know why the pressure was high. Was it angle closure? Was it open angle? Was it a steroid component which was playing a role? Because post-surgery, I have to give him steroids. That will again lead to a rise in eye pressure. Am I going to lower the eye pressure now? This drop in eye pressure with cataract surgery is only temporary. I'm looking at things 5 years, 10 years down the line. So now, is my cataract surgery going to be beneficial, or do I need to do both together? Is my surgery going to lead to a rise in IOP? So this is how your planning is all the time going to happen. Then what will you do if you've done a cataract surgery fellowship and not focused primarily on a glaucoma part? You have a patient who's got a neovascular glaucoma post-diabetes, and this lady is about 36 years old in both eyes. Her vision is finger counting, but when you give her mannitol and lower the pressure, her vision improves to 636. Will you do a cataract surgery for her, or will you try to focus on treating the diabetic retinopathy and the neovascular glaucoma and then trying to do a glaucoma surgery for her so that the pressure comes down and she can have some functional vision for life? Having a vision of finger counting without cataract surgery, having a vision of 636 after a glaucoma surgery and no cataract surgery done, is a long-term, patient's going to be extremely happy. So it's not just that cataract surgeons make patients happy, glaucoma surgeons can also make patients happy. In a long-term perspective, you've got to talk, you've got to counsel your patients. It's an ongoing process. And what will a cataract surgeon do after operating on a cataract in one eye? A glaucoma surgeon, after doing glaucoma surgery in one eye, has the option of doing another glaucoma surgery and more glaucoma surgeries in that eye later on. So just imagine the amount of work you have for yourself. Cataract surgeon can operate twice only. There's no third eye. Glaucoma surgeon can do so many such things.